Welcome everyone. Thank you for joining this webinar organized by BDVA with the support of the BDVA project in relation to the usage of data to manage the current coronavirus pandemic. So thank you very much to the speakers that are with us today. And I don't think there is a need to explain what is driving us to organize this this online session. I hope there are more like this. First thing I want to say is in BDVA, as a research and innovation community in big data and artificial intelligence, we think it's important for us to share our experiences, knowledge, evidence, and try to identify the best practices. So we think this is a good way to do it. There are also other ways. So we wanted to stimulate knowledge sharing through this session. Before we go to the speakers, we would like to know who you are. So we are launching now a quick poll for all the participants. So while I do my introduction, if you can tell us who you are, that could be ideal. Just to mention that in addition to this session and potential future sessions, we've been collecting information also about different solutions, initiatives, mainly on the request of colleagues from the European Commission, as many of you know. I just want to, I think I informed many people on the email, but I want to take advantage of this webinar to also say that the European Commission, DG Connect, in particular the Unit A1, they have facilitated a link that is now on the screen, and I will post in the chat, that you can use to actually input in a systematic way existing solutions and initiatives, and that way this will be collected in a transparent way and shared in more systematic way. So this is to inform you. Also, another point that I want to make, this session today, it covers some of the basics and very generic aspects of how we can use AI and big data. Also focuses, as you will notice, very much in certain models that are being used for prediction, statistical models. But there are other many aspects, like many people called my attention to different initiatives in data sharing and other things. We will launch at the end of this webinar a very quick survey, so you can actually input your ideas on additional sessions in the upcoming days, weeks, to cover other aspects of the current crisis. So saying this, also last remark before we go and introduce the speakers, there is a chat in the tool that you can use to post your questions. We have our colleague Tiblet from Philips, who is the lead of the Task Force 7 in healthcare in BDVA, who will help us actually to collect some of your questions and ask the panelists at the end those questions, and otherwise to keep them for future discussions. Now I'm going to close the poll, and I'm going to share the results so you can see what is the profile of the people attending this webinar. And saying this, I give the floor to our first speaker. Actually, she is the promoter of this webinar, Gabriela Catania from IDC. So Gabriela, I give you the floor, and thank you for being with us today.
Thank you, Anna. I hope you hear me. Yeah. And welcome to everybody. My name is Gabriella Cattaneo, and I am a research and policy analyst for ICT. I work for IDC, a global company specialized in ICT market research and consulting. And today we launched this webinar because the BDVA community wanted to open a discussion to share experiences and evidence about the best way to use artificial intelligence and big data technologies to meet the challenges posed by the first truly global pandemic since we are in the modern times, let's say. There is a new discipline which is called digital epidemiology. It means to combine big data analytics with methods from medicine, biology, social science, and statistics to understand and predict the course of infectious diseases. And we have seen really a lot of research and studies engaging in this analysis in the last period. Today, we will hear about predictive models and about the use of machine learning to anticipate and manage the pandemic. But I think we are also living in the largest, most dramatic and unexpected social experiment ever, as governments launch a variety of social distancing measures to slow down the contagion by the coronavirus. So we are also seeing in many countries the use of digital technologies, digital contact tracing systems and monitoring systems, and widespread digital surveillance to monitor the population, enforce lockdowns in a variety of ways and very different degrees of success. I think it's very important to discuss and talk about this. This is creating a huge debate. Are we welcoming Big Brother in our houses? Will we be able to send him back after the pandemic? Or we can use these technologies in an ethical and transparent way? I think this is something that we need to discuss and experience. But first of all, let's see why digital contact tracing has become a hot topic. If you look at this chart, it is brutal, but very effective in its relative simplicity. It shows the progression of COVID-19 by country, taking as a starting point the day when a country reached 100 cases. It shows the increase of cases in the following days. We can see that the growth of cases after the first 100 is similarly fast in many ways, with notable exceptions. Hong Kong, Singapore, Japan, in various ways, they have been able to never let the coronavirus take off. More interestingly, perhaps, South Korea is the only country which seems to have been able to stop the contagion on its tracks by employing a capillary test and tracing program, the voluntary use of a smartphone app, but without going to the level of surveillance employed by China. So we can see why in this chart, European governments are rushing to test similar approaches in order to find ways to manage the contagion, but also to avoid the continuation of lockdowns, which are very relevant. I only have a very few minutes and the other speakers will go more in depth on a number of aspects, but I wanted to share with you this chart. I have put together in the last couple of days, so take it with, it's really work in progress, but it shows a diffusion of a quick overview of the digital contact tracing methods which are being experimented by various countries, and I found really very many of them. I have positioned them on a scale from the lowest to the highest level of digital surveillance, use of personal data, from low to high. And I can, and this is important to understand and to use these different models. So the first step is about the government use of anonymized location datasets. This is something which is being used. I found evidence about it in a number of countries, Germany, Italy, Austria, Belgium, and so on. There is a plan in the European Union by EC Commissioner Thierry Breton trying to set something similar up for the whole of the EU. And this is also in line with the GDPR, the Global Data Protection Regulation, which allows the use of public data, personal data for public health needs. The next steps I found, and the next most frequent tool, is the use of smartphone apps with citizens' consensus. They are used for people to communicate their symptoms, ask for tests, in case they must be isolated, to be monitored, but also supported in their quarantine. The most important feature of these apps is allowing for the system to trace their movements in the days before the contagion and alert others who have been in their proximity. This is what South Korea and the other Asian countries do, is the most effective but also most contentious aspect of this approach. In the last week, several countries have announced apps of this kind, from Poland to Spain to Italy. In Italy, there is a call for solutions and apps which goes in this direction. Of course, it can be applied in many different ways, and this is where transparency and respect of people's rights is very relevant. But there are also several countries who are using personal data and from smartphones and other data sets, such as credit cards, payments, and other data sets, without necessarily asking for citizens' permission. Israel just passed a law which declares a state of war, and so the Secret Service unit, Shin Bet, can use surveillance in many ways in order to track and stop contagion. In Taiwan, they have an electronic fence system. Basically, there is an alarm which calls the police if a quarantined individual goes further than a few hundred meters from their home. So there are many different ways. Singapore has something similar, but is based on a much greater consensus because of the system of Singapore that you know is there is very much a state which is very invasive but protective. Also because they have foreseen and they have instituted economic incentives. So everybody who cannot work because of the virus is given some money per month and so on. But there is also the use of surveillance drones to find people violating quarantines. This has been used in Belgium, Italy, Spain, and China, so also in countries you wouldn't expect. And finally, of course, you have China with the full digital surveillance toolbox, facial recognition, QR codes, mobile data, cross-elaboration of data sets. So as you can see, there are a number of models. I think the key point here is the policy imperative. We need to use these technologies to manage the next phase of the lockdown because we cannot last forever. Otherwise, both the society and the economy will not survive such an extreme loss of freedom. We need to balance public health and privacy protection and human rights. The models we have seen of use of the different technologies cover more or less three main activities, three main aspects. Population control to enforce respect of lockdown and quarantine measures, tracing individuals positive to the virus and their contacts and informing them, building maps to identify infection clusters and the diffusion of the disease by area. So in many ways, these tools are also useful to feed data into the predictive and management models that we will be talking about. We already said that, at least in my opinion, China's model of intensive digital surveillance is not acceptable in Western democracies. On the other hand, we need for fast action. So a possible way forward is really to balance ethical and transparency requirement with effectiveness and centralized governance. And we'll hear from Luca Ferretti from Oxford a way to do so. But I believe that we will probably breach previous boundaries of personal data used by governments, and this is probably becoming a new acceptance level. So I would like to give the floor to the next speakers, and I'm very interested to keep discussing and hearing about the ways governments are going forward to implement these technologies and find the solutions so that we see how best technologies can help us and society without hindering and reducing our rights. So Anna, I will give you the floor back.
Thank you very much, Gabriela. I give the floor now to Daniel Calvo from Atos Research and Innovation. And please don't forget to put your questions or comments on the chat. This is for the whole audience. The floor is yours, Daniel.
Thank you, Anna. So good afternoon, everyone. Thank you first to the BDVA and to all the participants for having organized and for attending this very relevant session. So my name is Daniel Calvo, and I am the Head of Artificial Intelligence and Robotics in Atos Research and Innovation. And during this short presentation, I am going to talk about models to predict the spread and the evolution of infectious diseases as the one we are having now with this coronavirus. And I will try also to explain some examples regarding how big data and artificial intelligence technologies can support and improve the current models. So why is important to have this kind of predictions regarding the evolution of the diseases? Well, obviously, if we are able to early detect outbreaks of viruses, we can design and implement predictive policies that will avoid these outbreaks to become a pandemic. They are also important for governments and healthcare decision makers in order to respond to dynamic situations, because as we are seeing right now, for instance, the reproduction number changes with the time and changes between different regions. Also for operational management, in order to distribute efficiently the medical equipment between different regional hospitals and to acquire the needed equipment on time. For the hospitals, in order to optimize the use of the internal resources of the staff of critical elements like the intensive care units. It's also important to raise awareness, as we are seeing even now in Spain, in the very hard situation we are living. Some people is not respecting the social distance guidelines. So we don't have to rise a needed alarmism with these kind of predictions, but it's important for the people to understand the risks they are putting in all the society. Also to optimize the industrial production. We are addressing in this kind of pandemic situations the need to address low demand situations, or to prioritize the manufacturing on certain items. Obviously, also to understand the unavoidable impact in the economy, in the global economy. And finally, something quite important if we think about the long term is to learn from the current situation and to be prepared for potential seasonal outbreaks of the virus again, for instance, next winter. And in my eyes, when we talk about this topic, is quite relevant to emphasize that epidemiological models are an active research area with more than 1 century of history, and that digital technologies, AI, and big data are here to support this effort, but we are not starting from scratch. And in this slide, you can see possible categorization for this kind of models. We have risk assessment models that quantify the risk for a specific location, considering parameters like the hygiene or the weather conditions. Models that predict events like where and when we will have a new outbreak of a virus. Spatial models that are more focused on the geographical spread of the disease, or dynamical models that focuses on the evolution through a population, taking also into account the impact of the measures that the governments are putting in force. And as Gabriela has just mentioned, event detection models that use, for instance, these smart applications to detect symptoms and hotspots. One of the best well-known models, and of the most basic ones also, is the SIR model that quantifies the number of susceptible cases, infectious people, and recovered people using couple differential equations. And these models are characterized by some parameters that estimate the flows between these groups. And we can introduce even more complexity in this kind of models in order to consider that we don't have long-lasting immunity, that we have carriers that are people that do not recover completely from the disease, or expose people that have the virus but are not infectious yet. Another important parameter is the reproduction number, that basically describes the potential secondary cases that an individual primary case may produce in a susceptible population. And this reproduction number is characterized by, or is influenced by, the duration of the infectious period, the likelihood of infecting an individual susceptible in a single contact, and the number of contacts per unit of time. And it's important also to understand that this reproduction number changes between different diseases, as we can see, but also changes between different locations and even during the time. And in order to estimate the parameters that characterize this SIR model, normally we use field data and numerical or computational models, but it's a complex process because, for instance, these parameters are the aerodynamic chain. So some statistical approaches like Bayesian computation have been proposed, and also machine learning models are being reported in the scientific papers to estimate this parameter, and reporting good trade-offs between the accuracy and the performance when compared with other alternatives. As I said before, we can introduce further complexity in these models. For instance, we can develop a low-level detail spatio-temporal model that considers the evolution, the spread of the disease in a big city, in a urban environment that are normally have big movements of people between different areas. So traffic origin destination matrix in this context can be obtained from smart city platforms, from shared mobility providers, or from traffic authorities. And this data can be introduced in the equation of the SIR models. And in this way, we can evaluate, for instance, the need to reduce the public transportation service, or the efficiency of putting a quarantine only in a part of the city. In this way, minimizing the overall impact in the economy and in the rest of the society. Another very relevant example of the usage of AI was Blue Dot. This company not only raised an alarm about the rising of a new disease in Wuhan, but also was able to identify which cities were more likely to be transferred the disease using machine learning technologies to analyze travel patterns. And of course, some machine learning models are being used standalone to predict the evolution of the number of cases in different regions. For instance, in this case, modified autoencoders are applied, providing good accuracy. And what is interesting also is that using this approach, we can cluster the trends in the different areas, in different cities, and in this way, we will be able to develop more specific models. So as we are seeing, the data is going to have a very, very relevant impact in the type of the models, in the quality of the models that we are developing using AI and big data technologies. So if we get a look at which information is currently available, at global level, we see three main data sets that provide updates daily. In general, the information is the number of cases, deaths, recover, and the level of detail is per country, although in the US we have a bit more of we have also data for the different regions. There are also similar data sets at the national level, and the level of information varies between different countries. For instance, in Spain, we have just started to give metrics depending on the age or the gender during the last weeks. And in case of the South Korea, the metadata that is available is really interesting. So which are the challenges? Having access to high quality, complete, and accurate information for sure is going to be absolutely essential in order to decide if this kind of AI and digital technologies, big data technologies, are going to be valuable to support predictive models and to mitigate the spread of this kind of diseases. Honestly, at this moment, we don't have many data available in comparison with other diseases like the influenza, for instance, where we have 30 years of data. Also, the variability, it's a very complex problem. And as Gabriela has also introduced, we need to still comply with some privacy protection regulation, especially in Western democracies. So a final statement to finish my presentation is that the quality of the data is going to certainly determine the quality of the models, and at this moment there is a lot of uncertainty. And that's all. Thanks so much, and I am really interested in seeing the rest of the presentation and go on with the discussion. Thank you. The floor is yours again.
Yeah, thank you very much, Daniel. I encourage everyone to post questions on the chat. And now I would like to give the floor to Luca Ferretti. I need to give you this. Just give me a second, Luca. Okay, I don't say Luca in the call. Okay. No, here you are. Okay, so Luca Ferretti from the Big Data Institute at the Oxford University. Thank you, Luca, for joining us today.
Thank you. Good afternoon, everybody, and thanks for inviting me to this very interesting webinar. I will present on behalf of the Christoph Fraser Group at the University of Oxford Big Data Institute our results on a proposal for a mobile app-based digital solution for contact tracing and control of the COVID-19 epidemic. The main point of this epidemic, and the reason why this epidemic is so dangerous, is not only the rapidity of its spread, but also its impressive impact on ICUs and critical care units. This is the celebrated plot by Ferguson et al. In the recent report from Imperial College that shows that essentially in the amount of beds in this red line that are available in ICU are completely unbalanced with respect to all the possible scenarios that do not require hard lockdown in most countries, at least the US and the UK. The main issue here is therefore not to flatten the curve, but to smash the curve completely and stop the epidemic from going at the current speed. Now, why? This is an important point. There are many tools that classical epidemiology have at its disposal to face COVID-19, but they do not work. Physical distancing, isolation, and quarantine is either insufficient to stop the epidemic if done in a mild way, or has very high social and economic costs, as we know. The alternative of mass screening and testing and then rapid contact tracing is very hard to scale at the national level for a rapid response, either in terms of human resources required or in terms of manufacturing of the testing. And the classical weapon of epidemiology is vaccination, needs quite some time for the phase of development and trial. And after clinical trials, there will be some time where production is scaled up to the billion units required. So the only alternative is basically digital technologies for a faster and scalable response that could go very rapidly in a matter of days at a whole country level. For a mobile app is the following one. Basically, most individuals should have an app installed on their smartphones. The app will record all their proximity contacts in different environments, at home or public transport, work, and so on. And then once these individuals experience an onset of symptoms, they can report the symptoms via the app. They can request a test from the health systems. If positive, or if positive by symptoms, there will be an instant signal, an instant notification to all their contacts for the last 7 days or whatever is the right timing for the spreading of the virus, asking them to self-isolate for 14 days, advising other contacts possibly that they are at risk and they should maintain a higher physical distancing, and possibly decontaminating the locations that are most relevant for the initial NDVA case. The reason why this proposal is important is that essentially we need 21st century solution for the classical problem of person-person contact tracing. It is the most classical tool in epidemiology, and yet is not scalable enough. This system, if widely deployed, could stop the epidemic. Why? Here in this curve on the left, I'm showing you the infectiousness curve in time. So how many individuals are people infecting at every point in time after they get infected themselves. The two critical parts are the light blue one that corresponds to pre-symptomatic transmission and the dark blue that corresponds to symptomatic one. So most people either transmit the virus as pre-symptomatic, so before showing symptoms, or they transmit it after. And the key point is that most, say about half of the individuals, transmit it before showing symptoms, because the time of onset of symptoms is comparable to the time it takes for people to be most infectious. So this about half of pre-symptomatic transmissions is sufficient to drive the epidemic, and this is the part that must be stopped. People are essentially transmitting the virus without even realizing that they are infected. And that's the critical issue. Other forms of transmission that are tricky, for example, in green you can see environmental and asymptomatic transmission. We don't have clear understanding of what's their role, but it appears not to be driving the epidemic at present. Can stop the epidemic, of course, if done in a very fast and very efficient way, but it really requires high efficiency and very fast response time, less than 24 hours. In the plots here, you see in terms of the rate of success of both isolations and contact tracing, what would be the impact on the growth of the virus. In the red zone, the virus is still growing and you have not stopped the epidemic. In the green zone, the virus is not growing anymore and the epidemic is stopped. You can see that if you wait 3 days for the whole contact tracing process, there is no way this specific epidemic will be stopped. While if you have an instantaneous response with instantaneous notification to contacts, with no delay or a small delay, this can stop the epidemic for a wide range of efficiency parameters. That means that this can also be applied to democracies. That is the important point. So with having essentially non-compulsory uptake of the app. The important point is that this app with different parameters is useful at all phases of the epidemic. It is useful, of course, at the beginning of an epidemic or at the beginning of a second wave to prevent the initial spread. It is useful when the epidemic is getting momentum to stay in a state of smart lockdown to keep the economy afloat and avoid a generalized lockdown that would be extremely, and this being extremely damaging to the economy. It is useful for the phase of getting out of the lockdown to have a smart exit. So to release from the lockdown as many people as possible, but still keep control in case you see that a second epidemic wave could be starting. And then in a later phase, when you have essentially residual spread, but the epidemic is under control, this is useful to control the residual spread and block further waves. Challenges in this, mostly technological and logistic. There is a limitation in smartphone coverage and contact technologies. Now the standard choice for proximity contacts is low-powered Bluetooth exchanges, but it could be not sufficient. There could be an integration of multiple technologies, including geolocation and so on. A quite high uptake is required, so more than 50% of the people should have a smartphone equipped with the app. And there should be a high degree of compliance with the app recommendation to stay at home if one of your contacts has been infected. Also, it is crucial not to depend only on self-reported symptoms. So some scale-up of diagnostic testing across Europe is needed as well, and this is a common requirement for most of these applications. And of course, if the epidemic is growing especially fast, as it seems to be the case in Europe these days, some degree of physical distances could still be required. A moderate one that allows economic activity to progress, but that brings R0 a bit down in order to be controllable by the app. And most importantly, we need to understand as well of the science of the technology behind the app. This will be key because we need to have an app that works as effectively as possible in a short time. So the initial versions of the app will probably not be as refined as the one a few weeks later. And this is a critical point where all the community could play a role. There are quite important ethical issues, I would say, and it's key that these issues are taken seriously, because it's key to build trust and confidence at every stage. Even if the situation is an emergency one, we cannot risk a low uptake of these technologies because of low confidence. So privacy and data usage concerns should be at the forefront, possibly adopted by institutions that have a good record score for keeping up with the critical data, such as national health services. They should adopt a transparent and auditable algorithm to provide educated members of the public with an understanding of what's going on. And requires a careful consideration of the possibilities of strategies aimed to support specific groups, healthcare workers that are critical, elderly who could not have access to a phone, and the young who are probably critical for the spread of the disease as well, but often asymptomatic. And the important thing is that it should be deployed with individual consent, possibly some form of opt-out to combine an effective uptake with individual freedom. Now, I should say that we were very encouraged as a group by the discussions already happening with 3 or 4 European government partners, that we think that our ethical recommendations are being taken seriously at this stage. The question is, what can you do? Now, this is not a single solution, to be clear. This could be an important part of the solution, but must be part of a more integrated strategy with many of the other tools that Daniel talked about before, from surveillance, geolocation, spatial and temporal predictions, and so on. Still, from the point of view of the hardware, widespread diagnostic testing is still critical and will be so to avoid a generalized lockdown. And some degree of physical distances could still be important, at least in Europe, again, for the fast spread of the epidemic. The main thing that you can do is to contribute to this integrated strategy and to energize your government and partners to vocally support digital strategies, and especially app-based contact tracing based on this technology or similar technologies. There are now multiple countries and multiple projects ongoing, from Singapore to several ones in Europe. It doesn't matter what is the project, it matters that the technology is used and is effective. And if you are curious to find out more about the science behind this, here you can find information at this website. And I would like to thank the whole group, because this was a group project from the group of Christoph Fraser at the University of Oxford. Thank you very much.
Many thanks, Luca, for your intervention. Really very interesting input. Before passing to the next speaker, I would like to remind the audience that you can post questions, and if you don't know how to do it, in the panel where you see all the presentations on the right side, you will see like a red arrow. If you click the arrow, you will be able to see a panel, like a control panel, and there is a chat where you can post your questions in case you didn't know how to do it. So now I would like to give the floor to Paolo Giudici, and I make you presenter. And thank you for joining us as well. Paolo, you are still on mute. So I think you need to unmute yourself first.
I'm sorry. Good afternoon to all. Can you hear me now?
Yes, now, yeah. Yes.
All right. So, well, this talk goes back into the predictive models that were anticipated by Daniel. And in fact, he pointed out very clearly the kind of limitations of the SIR and error-based models that are not really fine-tuned to the specific location and time. And so our aim here is to introduce a model that is, of course, data-driven. So it's a big data analytics models, if you wish, although this data is still limited. A model that can be tailored to a specific country, region, or period of time. As you will see, it is a model that can adjust according to the specific circumstances of a specific country or time. This is a joint work with a colleague of mine, Arianna Agosto, from the University of Pavia. We are statisticians and data scientists who have been working in the area of digital finance for many years. And this is an opportunity to do something for digital epidemiology as well. So in the next slide here, you see a summary description of our model, which, by the way, is not just a theoretical model, but has been tested on real data. So we believe that for that reason, it is quite good in terms of performance. The model that we are proposing is explainable, so it's not a black box AI model that may perform well, but you do not understand what it's doing. So it has a limited impact on the people and on the awareness of the people that we believe is very important to address. An issue that is very important, especially if you want people to be compliant with the measure, is for them to understand what's going on. So the proposed model essentially is explainable. So although based on a stochastic process, it boils down to 3 parameters that anyone can interpret. And it is based on daily contagion data, so not on cumulative data. And it does estimate not one parameter, as it could be, the R0 or the exponential growth coefficient, but it estimates the shape of the contagion curve. So, providing that, a reasonable amount of data is inserted, it can give a prediction on where a certain country or region is away from the peak or after the peak, in an upward trend, downward trend, not only during first wave, but possibly afterwards. So we believe that this tool could be a good tool to monitor the situation and to decide, in an informed way, policy actions. Models are also continuously tested in terms of predictive accuracy. So that is what we say by reliable. No, is a tool that is not only explainable but also predictively accurate. But let's go to the models to see, if what I'm saying is in fact achieved. This is let's say, the methodological model. But by the way, we have a paper that first paper that we published in the SSRN 2 weeks ago. So you can go there for details. I can forward you the link later. So I don't want to go into too many technical details, but the idea is that the new cases in every day follow a Poisson model that is dependent on previous counts through the logarithm. So it is like an exponent, if you wish, an exponential model in which, however, the parameter is not constant, but it adjusts in time, depending on a short-term effect, the dependence on yesterday, and on a longer-term effect that describes, in a way, the population-specific context, which could be a particular type of measuring the cases, or particular actions, mobility restrictions or so, being taken. So the model has the flexibility to estimate all of these things through 3 parameters. So the omega is the intercept. It is like, if you wish, the fixed growth rate of the exponential model. The alpha describes the short-term effect, and the beta, the long-term one. Alpha plus beta is called persistence. When it is less than 1, the model is stationary, which means essentially that it has reached a plateau. So the kind of saturation of the contagion, number of people infected grows at a constant rate. When beta is greater than alpha, we have typically an increasing trend. So we are behind the peak, and this is the case of most European and American countries at the moment. When instead alpha is greater than beta, we have a downward trend, which is the case of China and Korea, for example. This slide, just says what I just told you before, so I can skip it. Let's see practically how it works. If what I told you is confirmed by the data. This slide shows the application of the model to the Chinese data, for which we have clearly a longer series already, about more than 60 data points. In this case, in fact, you see that the alpha parameter is higher than beta, at 0.81 versus 0.13. Both are significant, and this means that China is in a downward trend, and we know that China, it is in a downward trend, but still there is still persistence, so the contagion is clearly not over. The next slide shows the evolution of these parameters across time, in a retrospective way to test our model. These, in fact, tell you that the alpha plus beta started decreasing on February 4th. This is, in fact, when the peak in China was reached. So our model is able to get the peak. On day 23, instead, is when alpha becomes greater than beta, signaling a downward trend. And this is, in fact, when the downward trend, meaning a reduction in the number of new cases, was consolidated in China. So with this in mind, we have applied the model to other countries. So, having tested the model on the Chinese data, we applied to different countries. This doesn't mean that we feed the same curve as it could be for the other exponential growth model, for example. It means that we apply this, the autoregressive model to data of other countries. And this is what we got 3 or 4 days ago for Iran, South Korea, and Italy, that are the country that have a shortest delay with respect to China, and shows that for Iran, for example, the omega component prevails, which means that they are essentially on a constant path where dependence does not change over time. So an exponential model would be good for Iran. It could also be that the data is a bit variable, for many reasons, so it's not fully reliable. Instead, for South Korea, is only the alpha, which is significant, and this clearly means a downward trend. It also shows that the sum of alpha plus beta for Korea is lower than China, meaning, as Gabriella was saying before, that clearly South Korea was very good in containing the growth of contagion, better than China. For Italy, both parameters are significant, and this means that at the date in which this analysis was done, that is the 20th of March, Italy was still in an upward trend. our recent data, I do not present them here, but because I like to be cautious. The recent data indicate that alpha plus beta is declining in Italy, which points toward possible plateau, which seems to be confirmed by the data. This work, of course, you can find more detail in the paper, but now we are extending it to other waves of countries. In particular, we are working with the Center of European Policy Studies in Brussels, with Andrea Rend and Alexandra Cammas, to extend the models to all the European countries. Here in this graph, you show just the descriptive figures, like the graph that Gabriela pointed out in the beginning. And now we are building our models on this data. I mean, there is no time to tell you the first results, but I anticipate that essentially results confirm that France and Spain seem to be on the same shape as Italy. Germany is more difficult to understand because it is in a way similar to Iran, with a constant kind of trend. And some countries that did not adopt confinement measures, like the UK, for example, seem to have a very strong growth pattern, which is also newer because they started late. But I can be more specific on this, maybe during the next seminar, because I think that my time is over now. So I hope I gave you the idea. Essentially, what I said is to present a method, a predictive method, that goes beyond the traditional SAR or exponential growth model, in providing a tool that can be tailored to specific situations. And we believe it could be very useful for policymakers and potentially also for citizens, if this is implemented in their smartphones, to see what's going on and be more, let's say, more prone to adopt certain restrictive measures on their freedom. Thank you very much for the attention. I'm looking forward to your questions.
Many thanks, Paolo. I would like to give the floor now to Barbara Guardabascio, and here I think I gave you already the control of the screen.
Okay.
Perfect, Barbara. We can hear you well.
Okay. Okay. Thank you very much. And my name is Barbara Guardabascio, and I work as a researcher to the National Institute of Statistics, and I'm a joint professor of statistics at the University of Rome Tor Vergata and the Luis University. This is a joint work that I made with my colleagues Federico Brogi, an independent research, which tried to estimate the model of COVID-19 spread in Italy. In order to do this research, we start considering the situation. Just considering the population that normal epidemiological researcher can consider, and from following Chanlin et al. 2020, we know that we can divide the infected population in 3 different subgroups. So we have the cumulative confirmed cases that we say to be equal to IC, the active undetected cases, IA, and then confirmed cases under quarantine IQ. So we know that when we look at these 3 kinds of population from a point of view of a policymaker, what we have to do, first of all, is to consider the population IA, because it is the active one and the one that can leave you to create an epidemic problems, because let the contagion go on. In this sense, in order to estimate the situation in Italy, we start considering the model parameters in Italy, and we go to consider 4 parameters for making our estimation. First of all, we have the T, which is the incubation period from infection to symptoms. That is the time elapsing before the patient saw any symptom. And we know it is distributed generally as gamma distribution, because we know that the gamma is the distribution using for waiting time. And by epidemiology, we know that this value is around in mean 7.5. So we know that its range is from 0 to 15. Then we have the theta, which is in an ideal scenario, this is the parameter should be equal to 1. Indeed, this is the rate of confirmation once detected. However, since we know that the COVID-19 symptoms are similar to common flu, and given the low number of tests available, generally this parameter for Italy is smaller than 1. Moreover, we have the beta. The beta is the infection rate of a patient 0 before confirmation or quarantine, and it follows an exponential distribution as normally we know, and the contagion rate that we'll see later is 2.6 for COVID-19. Finally, we have the alpha, that is the if a confirmed case is isolated, the probability of being able to quarantine the totality of his contacts is given by this alpha, a parameter that belongs to the interval 0-1. And since COVID-19 spreads from person to person through droplets, as we know, it is impossible to trace all contacts. So for this reason, this alpha belongs to the interval 0-1. One of the most important parameters is the reproduction rate that we see in R0, whose values, depending on the values assumed, if it's greater than 1, equal to 1, or lower than 1, define the phases of the epidemic. So we know that when it's larger than 1, we have a supercritical case. When it's equal to 1, we have the epidemic that persists over time, while when is lower than 1, after period, epidemic is under control. For this reason, the aim of a policymaker should be to let this parameter go lower than 1. Generally, formula is given by this formula here, that is asymptotic and given by beta times 1 minus alpha over theta times the expected rate, expected value of t. However, in the ideal cases in which theta is equal to 0 and alpha is theta is equal to 1 and alpha is equal to 0, it assumes this structure. Now, what are the enforceable actions that the policymaker can do? To control the spread of the epidemic, we need that the production rate is lower than 1. In order to let it becoming lower than 1, we can reduce the infection rate beta by banning activity in public space, for instance, or make confirmation rate theta as close as possible to 1. It means that improving the accuracy of the diagnostic test, we let the population IA become IC, so they are checked. Or increase the quarantine rate alpha by tracking the confirming case and all their possible contacts. So we go to transform IA in IQ. We go to analyze the situation in Italy, and particularly we go to take civil protection data from February 21 to March 17, 2020, in order to analyze the policy adopted by our government, as well as in order to have a structured trend. We take the Chinese data from European Center for Disease Prevention and Control in order to try to make a forecasting. Consider that this work was made the 17th of March, so it means that the results are related to this data. Okay, model parameters. First of all, we say that we need to check the beta. It means the contagion rate. So as virus spread follows an exponential distribution, as we know, in order to capturing the beta, we just go to take logarithm of the number of active infected persons in Italy with respect to the trend time. So in this case, we go to join this equation, and from this equation we go to compute the beta, that is a simple given by the relation between the value of the fitted value of this equation at the time t over the sum of the previous seven fitted values. Indeed, we know that the contagion persists for 7 days. So for this reason, beta is computed in this way. So at the beginning of the epidemic in Italy, we have that the 29th of February, this value is equal to 0.352, and the reproducing number is equal to 2.46, while generally we know it should be equal to 2.6. Alpha is determined on the basis of the degree of the restrictive measures adopted by the government, and using the Chinese scale that you can see here, we try to schedule all the measures taken from government and assigning a weighted alpha depending on the level of population involved in each measure. So we start from a 0.001 when we just in 23rd of February we in Italy had the red zone, until the 80% when we have more restriction with the last decree that is in the level of March. To estimate theta, we use a proxy obtained by dividing the number of confirmed cases by the total number of tests carried out day by day. Once the value to assign to each parameters was detected, we estimated the effect of the combination of two measures in terms of infection reduction. So first of all, we consider the variation that occurs in the constrained theoretic curve with respect to the free one. After the first measure, that was the 1st of March, we get a reduction of the theoretic curve of 67.85%. Later on, we have other results that this one, the 50.55%, is the improvement that we have in reduction of the variation with respect to the previous period. So we see that each measure adopted by the government led reducing after the first one the contagion of almost 50%, from the 15% to the 20%. We try also to see between quarantine measures and high accuracy tests what should be the better solution, and in this case we try to fix the first the quarantine and let moving the number of accuracy of tests, and then we do the different cases for checking for quarantine, and we see that if we go to considering quarantine measures and we adopt the ones the policy of the 11th of March, we get a gain of 78.1%, while if just we improve the accuracy of tests but considering the highest number percentage per day we have of tests made during this period, we just arrived to 59.3%. So we know that for tests there is also some problems connected to the fact that day by day is impossible to do a number greater than a certain amount for the structure, for the viability of tests. So what we can get in terms of gain is 59% against the 78.1 that we can join if we consider the quarantine law. Both of them together let's join the 91.1% of gain. Once we assess the contagion effect of a measure, we used the three models to estimate the evolution of COVID-19 in Italy. So first of all, we make a simple regression between the contagion in Italy with respect to the trend of China, and we have the benchmark model. Then we go to consider Italian model restriction with full compliance. So we just consider the reproductive number multiplied by the last seven, the mean, the moving average of the cont eta variables, and this one is the cases in which there is a full compliance, while we consider another model that will give us the frontier of the model 2 in case of no compliance. In this case, so we substitute the rho zero, and inside the rho zero, the theoretical beta that we get at the beginning of our analysis. So we know is equal to 0.35, more or less. And here we see the results. So the green one is the line of the China trend. Yes. And this one is the blue one is the line of the minimum results that we can get, and here we have the frontier. The model proved to be performing forecasting tool in terms of peaks estimation, so we get the peak, and data are currently following the path of the frontier designed by the model, and the degree of accuracy of the forecast depend on several factors. For this reason, the curve resulting from the model is a frontier, which imply a minimum and maximum overlap with the real data, and according to the variation of benchmark parameter, and in particular level of compliance. And that's all. So the model are following well the data right now, and I suppose that is a good solution for knowing the path of the virus. Thank you so much. Thank you for your attention.
Thank you, Barbara. We really appreciate your input as well. So now for the whole audience, we are already out of time. We have received a long list of questions, but we are already, as I said, out of time. So I'm having a chat with the speakers, and we will take these questions and try to answer some on the email. Many of you ask me whether we are going to share the presentations. We will. And on the same email, you will receive a link to the presentations and the answers to some of the questions that have been posted in the questions area. Unfortunately, we don't have time for more, but as soon as we disconnect from this online session, you will get a series of questions, just very few. And in those questions, you can actually input additional topics for discussion related to this crisis, this pandemic at the moment, that you think we can also cover in the following days in relation to this. So thank you very much. I really appreciate very much the effort of all the speakers today, and also to the audience to be present with us today. And as said, more will come. Thank you very much, and have a nice day and stay safe. Thank you.
Thank you.